So last time when you came in the Hyderabad for the conference,
Yep.
That time you spoke about only for your movement disorders. You are doing this.
That's right.
And then in Bangalore, that time you started talking about the depression cases. You showed that time. That is in 2020, and now we are in 2022. So in these 2 years, how do you feel the DBS for depression is changed the way of you used to see that time and now?
Well, we so at time there's things that happened in the time. So over that period of 2 years, we've been able to recruit more patients to do surgery. So over that 2-year time period, we have done at least 4 more surgeries prior to today, and so with those patients, some of them have had profound improvements. All of them have been actually within the last year. So if you look at a total of it, we usually, when we look at response to depression, we see that there's an early response, but what we really see is at a year, what has really happened to them. Because sometimes there's different changes that occur with these patients with chronic depression. They may feel good, they may then have to readjust to the stimulation and then deal with new life problems. So they have some temporary, like minimal little relapses as they try to reaccommodate to their lives. So we've seen that, but what your question was, have we seen more? Well, we've just learned more. The more we do surgery in an area that's very unknown and experimental, which we consider DBS for depression still experimental, it's not FDA approved, we learn more. And that we see more patients that have improvement. That gives us more credibility that this is a real improvement and something that is durable. Since that time, we published 5-year studies of patients that we've seen that chronic stimulation has really been achievable to have sustained efficacy. It's not just the patient has improvement for a year and then that doesn't. Some patients who have improvement right away continue to have improvement. We've also noticed that patients who have come in for battery depletions have a relapse of their depression, and so we change the battery, turn it back on. Patient then undergoes antidepressant effect again. So these are things that we've learned in the last 2 years.
So it's only for the depression, or the patient will also with the OCDs?
So we've seen patients with OCDs as well. For other centers around the country and world have certainly done it. So DBS for OCD is much more common than DBS for depression. Just like for depression, there are many different targets that have been chosen for OCD. Typically, the target that is FDA approved is the ventral capsule ventral striatum target in the United States. But there's certainly other targets such as the ventromedial anterior subthalamic nucleus in France. It's very popular. Bed nucleus, the stria terminalis, also for OCD. These are also in the anterior limb of the internal capsule useful targets. Medial forebrain bundle is just as efficacious, and that's the target that we choose for depression OCD, as well as is in Germany. All these targets do have a very good effect, but like I said, OCD for DBS for OCD has been much more popularized than depression. Right.
So in your depression cases, have you choose interior limb of internal capsule?
So the only target that we have chosen for since we have to do the depression DBS under an FDA-approved clinical trial, we have chosen as our target the medial forebrain bundle, the superlateral branch, and that has been the target of choice, and that's the only thing that we have tried.
So you're trying to put only this thing because you want to go for that FDA approval for this?
We have to. So under the auspices of that trial, we have to implant at that target, but also we've had great effect, and so we really don't want to try a different target. We're learning more about things. Everything's a learning process. The more we do surgery, the more we learn all about what's good, what's bad, and how we can improve things.
So what you have seen that, like when you look for the dystonia for the DBS, which we always say that chronic stimulation is always beneficial.
That's right.
Like initially, I usually say to the patient that you cannot expect that remarkable things within 2 months or 3 months. So in your depression cases also, you say to the patient that once you will do it, it will take some time to...
So we make no guarantees to any patient with depression. We say that this is highly experimental and time will tell. And it's really a full year's worth of study when we make the claim, hey, that you have an improvement. And we use quantifiable measures, of course, just like in OCD, we look at certain depressive scales, such as the MADRS. Actually, when patients do have an improvement, once we reach a certain threshold of stimulation, typically patients have a pretty immediate improvement. So it's It's sort of like dystonia in a way because it takes a little bit of time to unravel things. However, we've seen patients with dystonia that have had improvement pretty rapidly after stimulation onset. We haven't had to wait 3 months. So hard to say. We know that at maybe 3 months is when you would expect to have a benefit, but if we have it ahead of time, that's very possible and